what the dual burden of disease in India. India is experiencing what is known as the dual burden of disease. In the past few decades, India has experienced or witnessed a dramatic rise in non-communicable diseases like heart attacks, paralytic strokes, hypertension, diabetes, cancers, essentially driven by lifestyle changes on top of the unfinished agenda of infectious and non-communicable diseases. Infectious diseases were very common when we got independence, but they continue to be still cause a significant burden of disease in India. There are emergences of new infections and re-emergence of old infections. And we were always surprised by the way the pandemics because of infectious disease have occurred. This century itself, we have witnessed two pandemics. The first was of the swine flu, better known as H1N1 influenza. And the second was, of course, the COVID is quite fresh in our mind. COVID pandemic is fresh in our mind. In addition to that, we continue to face outbreaks of Japanese encephalitis, malnutrition, and other problems. So this depicts that the non-communicable diseases have doubled from 29% to 58%, whereas the infectious diseases have halved in the last 3 decades. So India is experiencing what is known as the epidemiological health transition. In fact, there are a number of transitions which I'm going to elaborate them. And we face a double burden of disease of both underweight as well as overweight children. This is our Indian industrial study and funded by the ICMR and WHO, where of course we found that both underweight and overweight children burden is quite high. And this twin epidemics of diabetes, heart disease continues to advance and accelerate dramatically in India. And it is said that 20% of diabetes is preventable because it's all lifestyle driven. Our lives have changed. If you see the incidence of diabetes in 1970s, it was 1%. In the nationwide survey conducted by ICMR. Now it is nearly 11 to 12%, as per the latest survey done by the INDIAP study, where V. Mohan was the principal investigator, and we had all participated in it, published recently in the Lancet. So why this burden has increased? For any disease to be clinically manifest, there is always a confluence of genetic susceptibility and adverse environmental influences. There is no evidence to believe that our genes have changed, but there is definite certain non-controversial evidence that our lifestyle has changed. By adopting this unhealthy lifestyle, characterized by sedentary behavior, a nutrition transition from a diet to a diet which is calorie dense, high fat, and low in fiber and low in fresh vegetables, which actually leads to obesity, high blood pressure, diabetes, dyslipidemia, which are silent killers, and which ultimately clinically manifest as heart attacks. And also because of urban to rural to urban migration and urbanization and overpowering globalization, consumption of a diet which is atherogenic and thrombogenic, excessive use of inexpensive tobacco, lack of exercise, obesity, and all these factors actually are lifestyle driven, which are easily preventable. Unhealthy teens long back, a culture of coco-colonization and what is known as McDonaldization, which has crept into our children, And this indulgent lifestyles leads to these kind of adolescent obesities in the urban metropolitan cities. And we know that adolescent obesity is a forerunner of adult obesity. The cardiovascular disease epidemic in India is characterized by certain things, very important characteristic features. These include the early age of onset of heart attacks and paralytic strokes, and around data I will show, which these occur a decade earlier in Indians as compared to Western population. Not only heart attacks occur a decade earlier, but the deaths due to heart attacks also occur a decade earlier. Not only cardiovascular disease, but the risk factor, the traditional risk factors which are there, also their onset occurs a decade earlier in Indians. We know diabetes occurs a decade earlier in Indians. In type 2, I'm talking of type 2 diabetes. The mean age of onset of type 2 diabetes is 35 years in Indians as compared to 45 years in Western population. Majority of these risk factors like heart attack, like hypertension, diabetes, and dyslipidemia remains undetected, untreated, and uncontrolled, especially in the rural population, who have no time to get them tested. Not only that, the risk factors operate at a much lower threshold levels, and therefore we have different cutoff levels for defining obesity in Indians as compared to the Western population. We know the waist by hip ratio, which is for defining obesity, the waist circumference, which is used in metabolic syndrome. The cutoff level in Western population is 104 centimeters. Here it is 88. So the waist circumference also, the obesity BMI definition also is different. BMI for defining obesity is Western countries is 30. Here it is, in Indians it is 25. 23 to 25 is overweight. In Western it is 25 to 30. So what I'm trying to divide is that why this cutoff level South Asia specific guidelines have come where the cutoff levels have been lowered down threshold is because these risk factors operate at a lower threshold levels, at lower thresholds. There is higher case fatality rate. Once a heart attack occurs, the case fatality rate, especially in the rural population, is higher, and I've got evidence to say that. And I'll come to low birth weight later on. The risk factors occur at a younger age group in Indians. But why they occur at a younger age in the groups is again a question which has not been dealt very or researched well. One of the main reasons is air pollution is very common in India. Chronic diseases have been linked to air pollution. We know Delhi is the most populated capital in the world, and there is a high indoor pollution in the rural areas where biomass fuel is used instead of gas. And we have 1/3 deaths due to strokes, heart attacks, lung cancers are due to air pollution. And 50% deaths due to air pollution are due to heart attacks. It's not due to lung cancer, which is the usual thing. And Indians have one of the highest risk of developing heart attacks and diabetes in the world. Now this is again a study which is an INDIAP study which actually showed a very large nationally representative proportionally to population sampling, a government study funded by the ICMR, which actually showed that Indians had very high rates of diabetes and 11.2% of percentage, which is age adjusted and socioeconomic status adjusted, is the prevalence of diabetes. But what is more important to understand that there are a number of pre-diabetics is higher than diabetics. And the prevalence of pre-diabetics was 15%. The implications are very clear. The implications are that since the number of pre-diabetics are more as compared to diabetics, which means that the epidemic of diabetes will escalate further in India. This again, the same study which actually shows the problem of undetected and untreated diabetes. We know in the urban population, actually rural population, actually 75% of diabetes is undetected, and about 66% in the rural population is undetected. Diabetes awareness is therefore markedly low, and it's coming there, no? The implications of undetected, so high rates of undetected, untreated, and uncontrolled diabetes is because the diabetes awareness is very poor, and therefore more screening is needed. Same thing occurs seen with hypertension, where more than 75% of, 80% of hypertensives are undetected in the population and detected for the first time during this survey, more in rural as compared to the urban population. So more than 1 in 4 adults in India have hypertension, but only 10% of them have their blood pressure under control. And I'll go through the inter-heart study which we conducted, a global study which was with the principal investigator Salim Yusuf from McMaster University, Canada. And this is the South Asian data which was published in JAMA, where we looked at the cause of early heart attacks in South Asians as compared to rest of the world. And the study was conducted in 52 countries. We had more than 15,000 cases of first heart attacks as compared to equal number of controls. A study conducted all over the world in all continents except the Antarctica because no one lives there. But otherwise it is represented globally. And in South Asian data, we compared 5 South Asian countries from 15 centers and more than 1,700 cases of first heart attacks and 2,200 controls. In 47, compared it with 47 other countries. This is the largest study to be conducted in South Asians, and I led the Indian component of this part of this study. And the first study to compare data across 5 South Asian countries, and we came across with the similar results that heart attacks occurred a decade earlier. Our mean age of first heart attacks was 53 years in Indians, as compared in Western countries, in Europe and in US it was 63 years, and in the rest of the world it was 58.8 years, indicating heart attacks occur a decade earlier, first heart attacks in Indians as compared to the rest of the world. And 9 easily measurable, potentially modifiable risk factors accounted for 90% of heart attacks, indicating that if we are able to control these risk factors, we are able to, indicating that once we have able to control these risk factors, we will be able to prevent 90% of heart attacks. And what are these? These are lipids, ApoB by A1 ratio, smoking, even non-smoked tobacco conferred a two-fold risk, whereas a smoked tobacco conferred a 3-fold risk of developing a heart attack. Increased waist by hip ratio, hypertension, diabetes, psychosocial stress, and we have measured various components of psychosocial stress, and no time, I will not go into details, but lack of physical exercise, lack of consumption of fruits and vegetables accounted for 90% of heart attacks in Indians. Heart attacks, 70% of the first heart attacks occurred before the age of 60 years in Indians. Again, if you look at the socioeconomic transition which has occurred, we always thought that heart attacks are a disease of a high socioeconomic strata. And what this INDIAB study, which was again published in the Lancet, which actually showed that urban poor are in urban areas, there was higher prevalence of diabetes in the lower socioeconomic strata as compared to the upper social, whereas in the rural, it was the higher prevalence in the lower socioeconomic, in the higher socioeconomic strata, which indicates that there is a reversal of socioeconomic gradient, and that that the epidemic has matured. So in urban areas, it is not restricted to the higher, but it is in fact more common in the urban poor. Educational study, this actually shows that we have in the industrial study, which actually shows that the cardiovascular risk factors was inversely related to the educational status. And again, the CREATE registry data, which I was referring to in the earlier part of this morning, the study which was conducted in 89 hospitals and coordinated by St. John's Medical College, which actually I was a steering committee member, and 3/4 of the patients, quarter of the patients were from lower socioeconomic strata, and there was higher mortality after heart attacks in the rural, in the poor people because of lack of use of evidence-based life-saving medicines and interventions. Indians are more prone to develop heart attacks and diabetes because of a particular phenotype. For a given BMI, we have higher percentage of body fat, higher central obesity, and greater insulin resistance, which is known as sarcopenic obesity. Prevalence of dyslipidemia, very high. It is nearly 80% of patients had some element of dyslipidemia. Again, more than 1/3 were obese. physical activity, more than 90% of the population had no recreational physical activity. Glycemic control was very poor, and very low knowledge about diabetes awareness in the community. The Indian paradox is that when they, compared to high income countries, Indians probably have a lower risk factor burden, despite which their rates of heart attacks are higher. There are higher deaths due to heart attacks, a higher case fatality rates, essentially because the risk factors remain undetected, untreated, and uncontrolled. There are problems of availability, affordability, and accessibility of healthcare, and poor risk factor disease management contributes to it. And there are gaps are, in fact, much more pronounced in rural population than the urban populations. Now, having dealt with this emerging epidemic of heart attacks and paralytic strokes, we still have an agenda of infectious disease, which is still active, alive, and kicking. We know that the COVID-19 and the swine flu pandemic, and we still experience outbreaks of tropical fevers like dengue, malaria, leptospirosis, chikungunya, very common during the monsoon season. There have been global health emergencies. We continue to be threatened by new emerging infectious diseases, and there is WHO always declares public health emergency of global concern in number of diseases. You can see the number of diseases which have been declared as emergency by the WHO. And these are basically driven by zoonotic infections, and 80%, 75% of new emerging diseases and pandemics are basically zoonotic diseases. We are all aware, and let me remind you of the COVID-19 second wave, which was very brutal and devastating, and which was driven by the Delta mutant of the virus, which was 4 to 5 times more severe than the first wave, and the daily cases were more than 4 lakh in India, with more than 4,000 deaths per day. We were totally unprepared and unexpected, and we still have memories of people trying to find an oxygen bed during the COVID second wave. The challenge faced with this was pressed an unprecedented strain on healthcare, and COVID-19, in fact, was a very devastating, favipiravir, which was practically useless drug, actually became the most selling drug in India in April 2021 during the second wave. There was black marketing of remdesivir. So these are memories which we would like to forget, but we should remember, because it will teach us how to deal with the future pandemic if it occurs. We had seen the lockdown for the first time, which has again a very dramatic effect on the economy and also on chronic diseases remain unmanaged. You know that during the lockdown, patients' blood pressure, blood sugar, and heart attack, they remained undetected because everything was closed. And on the economy, it had a big toll. Schools were closed, so that was education was affected. Again, our own study which showed that lockdown had a tremendous impact on economy, education, and chronic diseases. A lot of services got affected during the second wave. After the COVID pandemic second wave, we had an unprecedented outbreak of mucormycosis. Again, there was a panic about shortage of amphotericin B, which was to be used for mucormycosis. It's very expensive, has to be used for a longer period of time. Then COVID was followed by a lot of symptoms of long COVID, where patients had loss of hair, chronic cough, weakness, brain fog, that means confusion, depression, and a lot of other things which were reported as a long-term complications of COVID. But one thing which India did extremely well was the record time in which we manufactured the vaccine, and the record time in which we, in fact, gave indigenous vaccines. Tropical fevers, we know that during this period in the monsoon, there are a lot of tropical fevers, malaria. In fact, now there is a changing epidemiology. When I was a student, everything was malaria. Any person who had fever was treated empirically for malaria. Now malaria is on the decline, but then again there is an emergence in some tribal areas. Malaria is re-emerging. But now dengue has come up. When I was a resident, there was no dengue. Dengue came somewhere in the late 90s and early 200, early this century. And it is now, dengue is increasing dramatically. This This monsoon, we had a very dramatic increase in chikungunya. Chikungunya was considered a benign disease, except that it caused a lot of morbidity in the form of joint pain and other things. But now, probably the virus has mutated. The type of cases which we are finding now, patients are now developing encephalitis, and some of them are dying also, which was very rare in chikungunya epidemic, which occurred in 2006. Leptospirosis is also increasing. Now this is the typical, this is our own picture, where we have this is a typical rash of dengue, where there are isles of white in the sea of red. Typical features of retroorbital pain, backbone fever, muscle, and fever with thrombocytopenia. Malaria, in fact, is a great imitator, which is considered in the differential diagnosis of any patient who develops fever is jaundice, and also considered as a very important differential diagnosis in patients who have fever with thrombocytopenia and renal failure. And in fact, we know that malaria can mimic anything and everything. Scrub typhus is again emerging and very common during the monsoon season. Ishkar, which is a typical feature, which is found in only 40% of the patient, and basically patients present with undifferentiated fever and therefore remains undiagnosed, and the serology becomes positive only after 5 days. It is transmitted by the tromboculid mite. Ishkar, which is considered to be pathogenic, found in only 35 to 40% of cases. This is the typical Ishkar. These are all our own patients, which have seen this, which looks like a cigar burn, and of scrub typhus, all our original pictures. And in fact, when we reported first cases of scrub typhus in 2012 in IGMC, when I was working there, no tests were available that time for diagnosing scrub typhus. Therefore, we had to send it to National Center for Disease Control, and we got back the report as being positive. And then the whole system of the public health that got activated, and we had an investigation subsequently. Then these were we are now seeing a lot of cases of scrub typhus during the monsoon. Leptospirosis, we have outbreaks in monsoon. They are more common in people who walk barefoot and do some paddy sowing there in the fields, farmers. In Mumbai, we know during monsoon, after a heavy rainfall, people have to wade through knee-deep water. That exposes them to leptospirosis. And one of the characteristic features is, look at the eye, which is suffused and icterus is present. One of the differential diagnoses of fever with jaundice is leptospirosis, and they may sometimes develop bronchopneumonia of this picture, which I'm showing here. And in fact, in 1998, there was an epidemic of fever in a small village near Nagpur, and a lot of them had developed fever. We did not know what is the cause of that fever, and there we investigated, and ultimately turned out that these cases were of leptospirosis. So leptospirosis is always a differential diagnosis. It's an important tropical fever, especially if a patient presents with fever with jaundice. Apart from malaria, one should always consider leptospirosis, especially in monsoon season. And it's very easy to treat. In more severe cases, injectable ceftriaxone, otherwise doxycycline is given in mild cases. Then this is again in chikungunya, where there was an epidemic of chikungunya in 2006. All of us may remember that there were whole villages, and there were reports of 4 deaths due to chikungunya in the newspaper, and I was deputed by the public health department to investigate. We did a verbal autopsy of those deaths. We did not we found that they were because of suicides and not because of deaths. And this is a typical hospital scene of a rural hospital, which in Karanja, very close to Nagpur, where so many patients were admitted, and all of them adopted a typical posture, a flexed attitude, flexing of all the lips. They called kukudu posture, and these villages, and these were all full of these patients. Whole villages were affected that time. Fortunately, that time there were no deaths. But now the chikungunya, which we are seeing now, is there has been a probable mutation of the virus, and we are finding more severe, and some deaths have also been reported. But during that epidemic, when the whole population was affected, this started somewhere in Africa in 1960s, but remained dormant and came to India in 2006 in a way, in a very dramatic way. But no deaths, more morbidity. But now, which we are getting in this monsoon, we got a lot of severe cases of chikungunya as well. This is because it is transmitted by mosquitoes, Aedes aegypti, and because there is storing of water for more than 7 days because of water shortage in the villages, the mosquitoes breed, and that is the responsible for that. And it is therefore prudent to use doxycycline in patients of undifferentiated fever, which works against both leptospirosis, it works against scrub typhus, and it also works against malaria. So in differentiated way, then this is again a case of human trypanosomiasis, which visit an emerging new zoonosis in India. In 2005, we reported the first formally identified case in the world of human trypanosomiasis due to T. vensei. A new form of human trypanosomiasis described for the first time due to an animal species. Human trypanosomiasis and vector species, that is tsetse flies, not found in India. It was restricted to the Africa. It was called human African trypanosomiasis, and this is our first paper which showed that human trypanosomiasis was caused by trypanosomiasis evansii, which is a parasite which is found in cattle. And this was reported by WHO, and this is the typical slide which we saw at that time. And then in my unit, this patient was admitted with high-grade fever, and his slide shows this very typical trypanosomes were seen. And the next day, when the fever subsided, this disappeared. But again, after a few days, he developed fever. Again, it appeared in the smear. And therefore, we did molecular studies. WHO was involved, and a molecular biologist from France had come, and he actually did the molecular studies, took back, and it was found that it was at 392 base pair, it was found to be trypanosomes, and more specifically, it was found to be Trypanosoma evansii. So we had formally identified that it was Trypanosoma evansii, a disease which is confined to the cattle, was responsible for that. We treated the patient with Suramine, a drug which was provided to us by WHO, which was not available in India. And we gave one injection every weekly for 5 injections in that patient with a lot of precautions. And then we did, and the patient recovered completely. And they did not have any symptoms subsequently. We followed the patient for 3-4 years. And then we did a survey in the village from where the patient came from. And preliminary serological survey actually showed a very high level of seropositivity, nearly 18%, indicating a lot of infection but no disease. Then human trypanosomiasis was ultimately reported in the New England Journal. We did further studies and found out that it was due to a lack of apolipoprotein L1, which is a triponephrotic factor which prevents the infection of animal trypanosomes in humans. And this patient who suffered from the infection actually lacked apolipoprotein L1. And this is the serosurveillance which was conducted by us in the May 2005 in the village Shivni, from where the patient had actually come, along with WHO officials. Subsequently, number of cases have come up of atypical human infections caused by animal trypanosomiasis. And Philip Trook was a molecular biologist who actually then reported from rest of the world as well. And now we are again going ahead with further investigations, and along with WHO and from French government, and we are now coming with the study is still ongoing, and we are still getting many cases of trypanosomiasis as well. Another very important is brucellosis. A patient presented with fever, and for 2 months duration and back pain. We did not know the cause. MRI showed this kind of a picture which typically said that it was tuberculosis. There was an abscess-like picture which aspirated it. It was negative for acid-based bacilli. Now for tuberculosis was not confirmed by any way. In this patient, we took the history properly. In both the patients, we've got the history that the patients were living in a village and they were milking the cow and drinking raw milk. And that is the typical way in which brucellosis occurs. It was then confirmed by sending the serology for brucellosis, and it was found to be positive, and the patient recovered with treatment with rifampicin and streptomycin. So this is my last slide. So we are facing a double burden of disease. We are getting flickering हो रहा है. We are getting what is known as majority of non-communicable. Can't see that, no? This is the last slide. So what India is experiencing dual burden of disease. In fact, there is a triple burden because lack of infrastructure is also there. So we have majority of non-communicable diseases like heart attacks and paralytic strokes, and the risk factors increasing. And this is totally preventable and controllable, despite which millions are dying. And we still continue to wonder whether the next pandemic will strike us, and whether infectious diseases are still common. India has the dubious distinction of having the largest number of diabetics in the world, and after China, and large number of cancers and large number of hypertension. Majority of these risk factors are undetected, untreated, and uncontrolled. And the problems of affordability, acceptability, and availability of health care, especially in the rural population. In addition to that, we have large burden of communicable diseases, and the imperatives of prevention actually dictate the urgency by which we need to empower the community and through health education and formulate and implement strategies that are lifestyle linked, population based, resource sensitive, and context specific through an enlightened policy of stakeholders and an energetic coalition of health workers. And development need not be associated with distorted diet and distorted lifestyle and disturbed health. Thank you. That's my last slide. And thank you for your patient hearing. Thank you very much.
Thank you, sir, for this masterly presentation, and more